My name is Michael Betel, and I'm the president and founder of the Fatty Liver Alliance. We raise awareness about the risks, causes, and complications of fatty liver disease and help those already diagnosed with NAFLD and NASH by advocating for access to approved treatments and care. I am incredibly excited to talk about an extremely important, much anticipated, and much needed practice guidance document for physicians and allied healthcare, enabling them to continue offering the very best of care for their NAFLD patients. The document is called AASLD Practice Guidance on the Clinical Assessment and Management of Non-Alcoholic Fatty Liver Disease. With us today, we have the lead author, Dr. Maru, professor of medicine at University of Chicago Pritzker School of Medicine, director of metabolic and fatty liver program, and member of faculty at the University of Chicago Hospitals, and one of the co-authors, Dr. Manal Abdelmalek, professor of medicine at the Mayo Clinic in Rochester, Minnesota. This incredible work that you all have done is 75 pages and 29 guidance statements. On behalf of all of NAFLD patients, all the medical professionals that will definitely use this document, thank you for all that you have done to put this together. My first and my second questions are, who should be reviewing and using this guidance document, and where should they start?
Yeah, so it's a great question. Thank you. And thank you for inviting me to kind of share my thoughts. It's really meant to be a practical guide for anybody who cares for people who may be at risk for fatty liver disease. So that means, of course, hepatologists and gastroenterologists, but also primary care doctors, endocrinologists, and the like. So the reason why that's so important is that the vast majority of people with fatty liver are actually in the space of primary care or endocrinology, for example. And so that's why it was really important for us to consider that perspective. And that's why in the sort of the development of the algorithm, we did exactly that. We tried to provide context depending on the context of use, and guidance for how one might go about doing that initial workup and who to focus energy on.
Thank you. And welcome, Dr. Abdelmalek. I thought it was going to be the other way around. We'd have you first and Maru second. But thank you for joining us also. And thank you for that as well. From the Mayo Clinic, Dr. Abdelmalek, thank you for joining us today too. I know we don't have a lot of time, so I'll jump in with some of the questions. When you're looking at, and I think this is going to be one of the first things people want to look at, is the who should be screened. And the guidelines are saying that not to screen the general population. So Manal, maybe you can start for a second. Why was that decision made not to screen the general population?
Well, I think for a few reasons. The general population is certainly a much larger cohort. And while we appreciate that obesity is increasing and even diabetes is increasing, weight alone is not necessarily a risk factor specifically for NASH. So we're caring mostly about those patients that are at risk, and those patients that are at risk for progressing to clinically meaningful endpoints, metrics that impact how patients feel, function, and survive. And that's driven by the presence of inflammation in the liver, the presence of NASH with fibrosis. And the data is suggesting that those patients who are highest risk, those patients who have diabetes, for example, age over 50, or 2 or more risk factors for metabolic syndrome, are those patients that we have to heighten awareness about to appropriately allocate healthcare resources to finding the patients at highest risks and targeting those patients specifically for the presence or absence of advanced and chronic liver disease, and also for the considerations of therapies beyond diet and exercise.
Okay, thank you.
I wanted to make one comment. So it's interesting because some people will actually ask the reverse question. They'll say, well, why are you recommending screening in people with diabetes and people with, first-degree relatives with NASH cirrhosis? And the reason is that we see so many people showing up to our offices way too late, who have been, probably had cirrhosis for a decade or more, who are showing up because their platelet count's low and they have bleeding from esophageal varices or ascites, which is, water accumulation in the belly. And those patients could have been identified a decade or 2 decades before. And so that's what we're trying to also make sure that there's a heightened awareness for that risk of advanced liver disease that can be quite silent in many people.
And what Dr. Rinella is bringing up here is so common for us. I mean, here she sits in the heart of Chicago, and here I sit in the heart of, Mayo Clinic in Rochester. And the stories that our patients tell us, and just yesterday I saw a patient, my doctor has been following my liver enzymes for 10 years and nobody ever told me there was something I need to worry about. They told me that there was nothing to be done about it. I had no idea. And when they actually do come to us and we do evaluate them, they have, bridging fibrosis or cirrhosis. And so the element of education, both on the part of our patients and providers, is so essential for this disease, and empowering them with the right care pathways and strategies by which to readily, simplistically be able to discern who is at risk and who's not is important. So we don't have missed opportunities to intervene early before advanced liver disease sets in.
Okay, thank you for that. And I did recognize too that the recommendation for suspected NAFLD, and I think it was called out obesity and metabolic risk, is to do the FIB-4, correct? And why was the FIB-4 chosen, or unless I misunderstood?
Yeah, so I mean, I guess it's not really in, so that would be in somebody who you're suspecting has fatty liver, for either because you saw it on an imaging test or because, as Dr. Abdelmalek mentioned, the metabolic risks that are cumulative in that person. But yeah, FIB-4 was chosen primarily because that's where most of the data are. It's free. It's essentially free, right? And so if you get basic blood tests on a patient, that's all you need to make that calculation. And so one of the most important parts, I think, about increasing awareness and identifying people who are at risk for advanced disease and having, getting quite sick from this, is just people having an easy way to risk stratify them. And that doesn't get much easier than that, because you don't need to order anything special. You don't need to order anything expensive. It's really just a quick calculation. It's not perfect, but perfect is the enemy of good, I guess, is if that's the way that saying goes. But you need to do something. Something is better than what we're doing now, which is not much.
And I think to extend that, the FIB-4, number one, not only is free, but it can be done as a point of care, assessment. The patient is in your office, you have the liver enzymes, you have a platelet count, their age, you can readily risk stratify somebody, and it performs very well for its negative predictive value. When patients aren't at risk of chronic liver disease, if their FIB-4 is very low, and when they're potentially at risk or at higher risk for liver disease when that FIB-4 is high, above 2.67. And so at least it gives you a flag, if you will, a yellow light, slow down, let me rethink potentially this patient's inherent risk factors. Let me ask about the presence of a family history of liver disease, or if there are any other risk factors. Let me look for these factors and at least know to refer on to a confirmatory test like a transient elastography FibroScan, or for somebody, a specialist, to opine on how much more testing should or shouldn't be done. And so the point of care is essential. The low cost, the element of no encumbrance of financial cost is essential, and it's readily available at anybody's office while the patient's there, and you're sizing them up, if you will, for an organ injury related to metabolic syndrome.
Right. And actually, the vast majority are going to be in that low risk range, too. So it's not like, we're identifying so many people that's going to overwhelm the system. I really don't believe that that's going to happen. I would be in a way happier that we were identifying so many people that we had to sort of be more stringent in who we referred, because it's really what I would like to see is less people developing advanced disease without just, even though they're getting great care otherwise. So
could you both clarify one point, please? When the patients are seen at the primary care level, at what point would the primary care physician, let's just say that's where we're starting at, refer for a FibroScan type of test, right, or to a specialist? Where does the line get crossed that would indicate the referral?
Manal, you want to take that, or I could take it too, but.
So I think if a primary care doctor sees somebody that they are otherwise following for diabetes or obesity or any end organ injury, such as hypertension, cholesterol problems, truncal obesity, somebody who is already, enriched with metabolic risk factors, the FIB-4 will empower them to also include the hepatic manifestation of metabolic syndrome in the equation of assessing organ injury related to metabolic drivers. And so if that early risk stratifier coupled with high risk clinical predictors for fibrosis, age, diabetes, 3 or more metabolic risk factors, and if that FIB-4 is higher than 2.67, I think that patient should be referred on for a FibroScan to confirm or refute the presence or absence of advanced hepatic fibrosis. And those patients who have advanced hepatic fibrosis or at risk for it should be seeing me. There are only so many hepatologists in this country to see the vast population at risk. And so what I would like to see, personally speaking, is I want to see my clinic filled with those people that I can serve in a advanced way. I don't want to necessarily see in a specialty practice those patients that can remain in primary care at the expense of getting somebody who is advanced liver disease less access to a specialist. So as Dr. Rinella was alluding to, this care pathway will allow us to, with more confidence, to retain in primary care the majority of patients that don't need to see a specialist, and to filter through those patients that are at highest risk access to care for a specialist, and hopefully leave nobody at risk, behind, although it is an imperfect system, but leave less patients behind who are at high risk and can get access to care earlier than would have otherwise been expected.
I think the challenge too is in that intermediate range, right? So if you're less than 1.3, that's pretty high negative predictive value. The person's going to be fine in primary care, at least for a bit. And then the higher than 2.67, but it's the people that fall in that intermediate range. That's where it really is going to depend on the level of comfort of the primary care or endocrinologist. So if they feel comfortable ordering a secondary test, like a liver stiffness measurement with transient elastography, for example, or another modality such as ultrasound with RFE, or even MRE, if they have access and want to do that, that's certainly within their ability to do that in order to sort of further risk stratify. And then if that's reassuring, they can keep them in their practice. If it's high, then they should go on for secondary assessment. The other thing the one thing that we put in there that is not, and totally open, I'm being open, this is not FDA label for ELF. The reason why we chose to put that in there, so ELF is approved by the FDA for prognostication in the setting of advanced fibrosis. And that's ideally how it should be used. That's where most of the evidence is. But we put it in there as an alternative for people who didn't have access to a FibroScan and wanted to do a secondary test. And so that will, again, if it is elevated, would sort of add further evidence that the patient should perhaps be referred if the FIB-4 is greater than 1.3. So that's the reason why that's in there. It's to sort of help capture people who didn't have access to those imaging stiffness measurements.